the complex, the QRS is fairly wide, and he presented to the emergency department, and the EP, emergency physician, regarded as a VT and gave IV imidazole, and it terminated. And this is the resting ECG. And the resting ECG, we can see clearly the pre-excitation, which is negative in 1 and AVL and positive in V1 with incomplete RBBB. So we proceed to ablation in July 2024 with the 4-wire study with the RV catheter in the APES. We performed a baseline retrograde study, which revealed the concentric activation with the earliest A in CS910, and also you can see in a later EGM in the last 2 weeks with the shorter VA interval. So we also we performed subsequent antegrade study, which revealed prominent pre-excitation. At that time, we feel that it is concentric, and the arrhythmia is induced with pacing from CS910 with 600 and 240 atrial stimuli. And it is, roughly speaking, it is a concentric activation pattern. We assume that it is a concentric activation pattern with the earliest activation in the CS910, and we proceed to MET from the right side with pacing from V. And we did found a few good signal around his region, and we ablate for several sections. But the after the final section, it reveals that the patient become a little bit unstable and with junctional return. And so we decided to stop with the presumed diagnosis of right-sided parahesian accessory pathway. And immediate post-procedure, the patient also developed right bundle branch block pattern. And so the patient later on put on propafenol and bisoprolol, and we plan follow-up. But the patient continued to have symptoms despite our medications, and so we plan for second review during Prof 1 visit on October 2025. And after reviewing the ECG, we plan ablation again on 15 October 2025. And this is the EP study setup, and this is the ECG before the ablation. And the resting ECG pattern is exactly the same as like the first ECG, the first resting ECG, with a negative delta wave in 1 AVL and positive delta wave in V1 with incomplete RBBB. So during this review from the surface ECG, we can recognize that since the delta wave is negative in 1 AVL and positive in V1, so we think that it might be probably the pathway is from the left free wall. So we proceed with the study. So this is the 4-wire study with the with the RV catheter in the APES. So the we performed the retrograde study first. In the retrograde Wingibud study, we Wingibud at 280 millisecond, and we can see it's a concentric activation with the earliest A in CS 910. Alright. So this is the ventricular atrial stimuli, and we perform the ventricular atrial stimuli with S1, S2 of 500, 450 millisecond, and we can see the VERP with 500, 290 millisecond. And we proceed with antegrade study, and in the antegrade study for atrial Wingibud, we can see the prominent pre-excitation with shorter AV interval, especially in the CS1, 2. So the AV Wingibud is observed at the cycle length of 270 millisecond with the 2-to-1 conduction block from accessory pathway to AV node. So with a view of previous uh, uh, assumption of Parahesian pathway, we now have to show that whether it is really of left-sided free wall origin. So we compare the RV apex pacing and RV OT or high septal pacing. So in the RV apex pacing, we can see there is a fusion of the AV node and left free wall pathway, but in RVOT or high septal pacing, the the VA pattern is a bit split with the earliest B as noted in the CS1, 2. So we'll proceed with tachycardia initiation, and we pace from the CS5, 6, and the tachycardia was induced at CS5, 6 with S1, S2 or 600 and 230 millisecond. And in the tachycardia, we can see that the tachycycle length is 292 millisecond with a long VA interval, and also the VA interval is shorter in the CS1, 2 in the tachycardia. So with that in mind, we conclude that it's a left free wall septal or left free wall pathway, and we proceed with septal puncture. So after the puncture, we proceed to map at the left free wall region, and with pacing from the CS7, 8, we can see a clear good signal at ablation 1, 2 with a sharp signal seen here, likely to be pathway potential. So, and we measure the ablation A with the um, uh, we measure the ablation A with the surface V, and it reveals a very early signal, 46 millisecond. So we proceed with ablation with the St. Jude 7 French catheter with 55 watt and 65 joule with with irrigated catheter for 90 milliseconds. This is the position in LAO view, and quickly after the radiofrequency ablation, there is a split AV fusion can be observed just 1 to 2 seconds after the energy application. And we also perform the booster application just medial and lateral to the dedicated site. So this is the post-ablation ECG, and we can see that the pre-excitation has been gone. So today I would like to point out that careful evaluation of clinical tachy ECG and EGM is of paramount importance in the correct diagnosis and planning of SPT ablation. And in our case, in the second part of the tachycardia is mostly antidromic. And this kind of antidromic tachycardia can be misleading, and we also cannot know that whether the first ablation we eliminated the retrograde limb and or as it is a dual accessory pathway, or it is simply a free wall, left-sided free wall AVRD in the fast hand. And it also illustrates the importance of differential pacing in EP diagnosis of SPT. Thank you very much.
Thank you for your presentation. Any question or comments from audience?
Can you show me the first slide?
Yes.
So I didn't see the HRPC at the first case, de novo procedure. HRPC, you show the maybe I missed, but is this HRPC?
Yes.
Okay. Oh. Okay.
Sorry for the incomplete EGM, because the store EGM is something has been, cannot be found.
But I think in this, the HR pacing, during HR pacing, I wonder we can see the His-bond potential or not. Did you see the His-bond potential during A pacing?
Can it be that one?
Okay. So why did you think this patient has dual accessory pathway?
Because the first ablation, we get a very good AV fusion signal, and after the first 3 or 4 section, we did get a VAD during ablation, but yes, and we cannot and also we cannot get, but the antegrade circuit still comes on after the ablation. So I think that probably the retrograde limb is there.
Because the wide QRS tachycardia ECG appearance and EGM, the activation sequence is very similar, and the de novo case and the read procedure. So I guess there was single tachycardia, could be single tachycardia, but at the de novo case, you try to ablate the retrograde limb of this ABRT, and the anterograde limb was through the high lateral accessory pathway and coming back to AB node. So
Yes.
I guess that's why you tried to ablate you thought it was a parahesian, but actually it is antidromic ABRT. That's my thought.
Yeah. Thank you.
One question from audience. Did you have decremental conduction to the atrium during V extra stimulation test during the first procedure?
Yes, but it is quite minimal. Yeah, decremental conduction, but it's quite minimal. In the, yeah. Sorry.
The announcement from the hospital. Ignore that.
So Dr. I think we need to discuss regarding why during V-pacing, the activation sequence of CS is proximal to distal. If it's a lateral accessory pathway and it has both anterograde and retrograde conduction, it should be the CS1 to atrial activation should be earlier than the proximal CS, but this patient shows consistently CS proximal to distal retrograde conduction pattern. So
I think this
it made a confusion.
Yeah. I think this accessory pathway, left lateral accessory pathway, has weak retrograde conduction property. That's why this patient has only antidromic tachycardia. Very rare. Usually, retrograde conduction through the accessory pathway is much stronger than antegrade conduction. That's why the concealed accessory pathway is more common than manifest accessory pathway. However, rarely the opposite property can be. So this patient has only left lateral accessory pathway with very weak retrograde conduction. And also I think if you pace the left ventricular pacing at the first session, you might not be confused. Yeah.
Oh, yeah.
One question from Maniel. I think ERP retrograde accessory pathway is longer than VA block cycle length of AV node infra his at this pacing cycle length. What do you think? Can you read the chatting message?
ECG?
Message chatting window.
Click the chatting window. There was one question from Cambodia, my friend Dr. Maniel. And good morning, Maniel.
Good morning, sir.
How are you?
I'm good. A long time to see.
Okay.
Thank you. Yes. So I wonder the question from Professor Park about the changing activation sequence from distal to proximal. So I think maybe accessory pathway ERP is longer than VA block cycle length. So I wonder what is the VA block cycle length in this patient.
Oh, VA block cycle.
Yeah. So that's why we can see block in the accessory pathway change the activation sequence during V-pacing.
I fully agree with Dr. Maniel.
Too late.
Yeah. So it's the ERP difference in this patient has relatively long ERP accessory pathway. That's why the retrograde conduction is through the AV node. But another thing we need to consider the pacing site dependent issues, because of RB pacing site is far away from the accessory pathway, then it cannot reach to the high lateral accessory pathway sometimes and make a consent reactivation. So easiest way to differentiate the long ERP or the accessory pathway far away from the ventricular pacing site is when you puncture the transeptal puncture and enter the ablation catheter to the left atrium, then you can put your catheter to the left ventricle and pace from left ventricle. Then it is easier to differentiate the retrograde conducting accessory pathway or just the anterograde conducting accessory pathway.
Yeah.
And Dr. 김민 질문이 뭐였죠?
대답. Alternatively, you can pace high RVOT as second session.
He did. Right?
However, at first session, he didn't pace high RV.
Yes. We only in the first ablation section we only did the pacing from the RV apex during tachycardia for entrainment study, but did not perform any other differential maneuver. So that's why we are misleading here.
Dr. Taintum, could you please
Yes.
explain in detail you show the differential pacing for RB outflow tract pacing and
Yes.
RB apical pacing, but
Yeah.
I cannot clearly see the activation change at that time. Could you please explain a little more about that? It's RB outflow tract pacing.
Yeah, it's RV outflow tract pacing, but actually the capture signal here, we only got the high septal pacing. So that's why, yeah.
So still the proximal CS activation is earlier than distal, right?
Yeah.
Sometimes we see this kind of high lateral accessory pathway conduction. But the tip is if you pace from left ventricle after transeptal puncture, you can differentiate it. And also this high lateral accessory pathway is very sometimes difficult to ablate because as you know, the coronary sinus and great cardiac vein runs away from the true mitral annulus and high anterolateral side. So
Yeah.
we have a clear reference catheter in the 3 o'clock to 6 o'clock coronary sinus because it almost overlaps with mitral annulus, but the more and more distal high lateral area is separate. Coronary vein and the annulus is separated. And that position is sometimes very unstable to make a good catheter contact. But you ablated by single bond successfully.
Yeah.
Congratulations.
With the help of Prof. John.
Yeah, you're very skillful.
With the help of Prof. John.
Dr. Ting, can I speak?
Yes.
Can I speak?
Yeah.
Hello. Yes, I'm Professor Taleswee from Nodoklapa General Hospital, Yangon.
Yes.
I thank Dr. Ting for presentation the interesting case from Myanmar on behalf of Myanmar. I would like to make one suggestion, and can you please show me the slide of the ECG with the atrial pacing, EGM with the atrial pacing?
This one.
Atrial pacing, please.
A pacing.
A pacing.
This one.
Yes. And in my opinion, I think in the A pacing as well, on the CS display, AV is quite close at the distal
Yes,
CS,
Michael.
I think.
Yeah.
Compared to the proximal CS 910, AV is quite close at the CS12.
Yes.
And I saw on the EGM that with the sinus beat. And can you please show me the EGM, intracardiac EGM on the sinus beat, please? I think this is still a winky bug.
Yeah.
I would like to see the ECG with the sinus beat, not the basing one.
Yeah.
Very initial, I think. Yes. On the sinus beat ECG, yes. On the, yes, previous one, please.
No, this
And
one
I
is
think it's on the right side. This is the one with the sinus beat. It's okay. Previous slide, yes. On the very right side of the screen is this is the end of the pacing, and I can see a sinus beat with the intracardiac EGM on the CS display. On the sinus beat as well, the AV is quite close as CS12, and I think we can get some clue that this pathway is on the left side by seeing the ECG and EGM in the sinus rhythm, not the pacing. So I think when you do the retrograde pacing from the V, the earlier CS is in the 910. I think it is the nodal conduction and maybe the nodal conduction. And is it decremental when you pace from the V? Is it decremental? Can you see the decremental property of the AV node?
Decremental property is not that prominent, just a minimal
Yes.
decrementation. Yes.
Yes. That is why maybe you interpret on the first time it is the retrograde conduction from the right-sided accessory pathway, maybe. But when you see the, when you see the long VA interval on the retrograde V conduction, maybe you might think that this is the nodal, but you are not seeing the wingy bucking. That's why you think this is the maybe retrograde right-sided pathway. But this is on the right side when you are in the sinus rhythm. AV is quite close as CS12. And then maybe from this clue, you can guess that this is the possible left-sided accessory pathway. Yes, but retrograde is maybe from the AV node or maybe from the right-sided non-decrementing accessory pathway. This is the first my impression. So when I usually do the EP cases on the Wolff-Parkinson-White syndrome, first thing is I interpret the surface ECG and I just guess the site of the accessory pathway. But this first guess may not be the final decision. So we have to see all the clues from the intracardiac ECG as well. And when I see the AV is close SES12, my first thought will be, is the accessory pathway from the left side? This is my first thought, and I'll do all the necessary simulations, and then we can finally decide which we should ablate. So thank you for your presentation. This is the good learning point that we can have something like a wrong impressions when we are doing the active cases. This is a very good example because we are seeing the ECG, we are doing the cases, and we can make the something like a wrong impression from the something like tricky EGMs. Yes. Thank you for your presentation. This is just my opinion. This is just my opinion. Yes.
Thank you for your comments. Any other question or comments from the audience? Professor Kim Min from South Korea showed his opinion. This patient has RBBB, and RV apex pacing shows early far field in CS1, suggesting a block in the RBB that is quite distal. How do you think? Professor Kim Min, can you hear me?
I can hear you.
Okay, please explain your opinion.
Just opinion. Because sometimes we experience in RBB patient during RBA pacing, maybe the ventricular activation pattern depends on the block site, because in proximal block site, ventricular pacing can activate retrograde the septa earlier than the distal block case. So I think this patient bypass tract has no retrograde conduction earlier conduction compared to the AV node. So maybe it can also the distal RBB can attribute to, I think, this phenomenon. So it's just my opinion. Thank you.
Thank you. Yeah. Any other comment? What do you think, Professor Park Han-jin?
I agree with Dr. Kim Min that distal RBBB might have contributed in less retrograde conduction during RV pacing.
Hi, my name is Tae Wang from NC University in South Korea. And did you see, is there only, when you do the EP study, do you see the only one morphology of the sustained tachycardia? Is there any different morphology like RBBB or LBBB pattern?
Do you mean in my case?
Yeah.
Yeah, it's only one documented tachycardia, but later on he complained of palpitation, but that time we did not catch up any clinical tachy yet.
So if there is some kinds of two morphologies of the tachycardia, with one thing is LVPB and one thing is the other, then you can see and the difference of the cycle length of tachycardia when the LVPB morphology, then you can think about the left side accessory passive.
Yeah.
If there was another sustained tachycardia, I think.
You are mentioning about
Yeah.
the Kumail's
Kumail's
law.
law, yeah.
Kumail's law. Okay, so it is very interesting case of antidromic AVRT, and we learn from this case. First of all, we need to carefully observe the surface ECG, and we can have a clue from the surface ECG first. And during EP study, complete EP study from pacing from ventricle, atrium, and during tachycardia, his refractory PVC or APC is important. And the last one is the last one is I usually ablate the WPW syndrome during sinus rhythm. Of course, there's the exceptional case. During sinus rhythm, we can observe the AB ratio and accessory pathway clearly. So it is easier to ablate and successfully ablate the WW syndrome. So during second case, you ablate during sinus rhythm. Am I right?
Yes, yes, during sinus rhythm, yeah.
So I always try to ablate the integrate the accessory pathway during sinus rhythm. And the last one is, how did you confirm the complete ablation of accessory pathway in your procedure? That is my last question.
Yeah, in this case, yeah, because it's the split, we get the very rapid split AV signals just 1 to 2 seconds after the procedure, and also the after the extensive retrograde and antegrade induction, and even with isoprenaline, the patient did not get any tachycardia. Yeah.
Okay. So in my experience, it is the practice pattern that I always try to put the ablation catheter LB, and even after successful ablation, I tried LB pacing whether there is a retrograde accessory VA accessory pathway conduction, because some patients, after eliminating the delta wave, some patients recur the ABRT by CBT pattern. So performing the retrograde conduction by LB pacing. Also, I use adenosine to, after blocking the AB node, whether there is the remaining accessory pathway or not. That is my practice pattern.
Yeah.
I enjoyed your case very
Thank
much.
you. Thank you, sir.
Thank you for your question and comments. Any other opinion about this case?
Okay.
You have something to say?
No, I didn't.
Okay, thank you for your presentation. Nice case. A lot of interesting points, and you have to learn.
Thank you very much, sir.
Thank you so much. Please stay healthy, and see you next conference.
Yeah, thank you very much, sir.
I appreciate.
Thank you.
Thank you. Thank you for your comment.